Okay, our next presenter is Dr. John Anderson. And let's see, Dr. Anderson, we have already introduced you and looking forward to your presentation on patients and their caregivers, challenges of chronic conditions on mental health. So if you can share your screen, please.
Good afternoon, are you hearing me?
Great. Welcome, Dr. Anderson.
Thank you. And thank you to all of the participants, and thank you, Ms. Moderator. Okay, so, chronic disease is the condition that I see on a daily basis in the Department of Internal Medicine at Georgetown Public Hospital. And I've seen so many different responses to chronic disease that it has caused me to think deeply about it in terms of how patients respond to the challenge that a chronic disease presents. Just checking, is everyone hearing me?
If you could maybe speak a little louder.
All right, excellent. So a diagnosis with chronic disease has the potential to profoundly influence a person's quality of life, as we can imagine. Accompanying the daily challenges that chronic conditions bring is the emotional turmoil as the financial demands that are burdened upon the patient as that relates to the diagnosis and what they have to provide to comfort the diagnosis in some cases. It really creates a situation for the patient that is difficult. And then of course, patients have to do follow-up at specialty clinics, et cetera, And so what that does to the patient is to add a burden to the patient and to challenge the patient's coping skills. Now, on the flip side of that is that mental health problems are associated with cardiovascular disease, Alzheimer's, pain, and other chronic physical problems. So as you see there's a bi-directional relationship between chronic disease and mental health. Now, in terms of the global statistics, chronic diseases kill 41 million people each year worldwide, an equivalent of 71% of all deaths globally. Now, in the region of the Americas, of which Guyana is one of the countries, 5.5 million deaths are by chronic diseases. Each year, 50 million persons, 2.2 million in the region of the America, die from chronic diseases between the ages of 30 and 69. So over 85% of these.
Excuse me, Dr. Anderson.
What I'll do for the rest of the presentation is to discuss this topic by cases. And so let me tell you a bit about the global statistics and our local statistics as well. So as I was saying, each year 15 million people, 2.2 million in the region of the Americas, die from chronic diseases between the ages of 30 and 69 years of age. Over 85% of these premature deaths occur in low and middle income countries. Cardiovascular disease accounts for most of these deaths, and 17.9 million people annually, followed by cancers 9 million, respiratory disease 3.9 million, diabetes 1.6 million globally. These four groups of diseases account for over 80% of all premature chronic diseases. And as you see here in the Guyana statistics, this was taken from 2009, where you can see a number of chronic diseases, respiratory disease, asthma, hypertension, diabetes, and how they are represented by sex. In the clinic that I work at, all of my patients are patients with chronic diseases. It's important that we understand that there has been a paradigm shift in the way that we think about chronic diseases. Traditionally, there was a deficit-centered model that basically looked at how the patient could not cope with the burden of the chronic disease. However, we have shifted away from that, and now we're looking at chronic disease from a different perspective. And so we're looking at it now with respect to how are people coping, what kind of coping skills do persons need, and what kind of coping skills do persons have to deal with the challenge of chronic disease. So I'll start with my first case. This is a case of a 50-year-old female who presented to my office with joint pains, joint swelling, difficulty mobilizing, in general ill health. And she was brought by her mom. And the mom indicated that this patient was an athlete. She was a dancer who could no longer enjoy these activities because of joint pains. And for the past 2 years, the previous 2 years, they spent time and efforts trying to come to a diagnosis. She had no known history of any illness that was of any concern. She was on painkillers at the time. And when I saw her joints were swollen, she had difficulty mobilizing, she could barely walk. We did a workup, I did a thorough workup, and so at the end of it, she was diagnosed with lupus, with the systemic lupus erythematosus. In Guyana, we say lupus for short. Her lupus was pretty bad in the sense that there were markers for kidney disease early on in the diagnosis. So I knew upfront that I was going to deal with a patient who was eventually going to go on to develop some severe kidney disease within the context of SLE or lupus. And so this patient eventually developed kidney failure and was put on dialysis as a result. So her blood pressures began to go up, as you know. Kidney disease and blood pressure, there's an association there due to the interesting pathophysiology associated there. And so she became hypertensive. We treated that. We sent her to follow-up care at the dialysis center and with her supporting team as well. So at this point, the patient is currently in the USA accessing care for her. She developed eye disease. She doesn't need a kidney transplant, which her father will be providing the kidney for the transplant, but she's currently in the US. Now, what are the factors leading to mental health challenges in this situation? So one, you have frustration regarding a lack of diagnosis for the past 2 years prior to coming to the clinic. They couldn't find a diagnosis. So the mom was worried, the patient was worried, and the extended family was worried. And that situation created a burden for those folks. Then there was a financial burden, the cost of previous diagnostic evaluation. There was lost time from work. The mother lost her job. There was a time demand to provide care for this young lady. And then, of course, she had to depend on finance from the young lady's father and other relatives. By this time, the father and the mother were not living together. There was a good supportive relationship. The mother expressed hopelessness as she said to me, "This is my best child, Dr. Anderson." And I mean, as a parent, you don't want to say that you have favorites, but she was very open that this was the child that was pretty close to her. The young lady was a teenager pursuing her academic goals, and there was lost time for the patient's educational advancement as well. What intervention that was applied there? So what happened? I called the family conference to discuss and address disease management, to talk about prognosis, to talk about options, treatment options, and how the disease will progress. It's important to note that listening to the patient's needs in this situation was very important for them and for me. So I communicated with the patient, with her relatives, so that they could understand what was happening with this young lady. Reassurance of the patient and relatives that their best interests was being catered for was also something that was heavily focused on. We made a point of doing that. And then she was referred for support counseling with our social worker. So in this case, we see here a family being affected by a diagnosis that really is not one that anyone wants to have. And so, because a lot of patients with lupus eventually go on to develop lupus nephritis, as is the situation with this young lady. Now she is at the end stage renal disease, and she now requires advanced care out of Guyana, which was very costly as well. So one can imagine the burden that this placed on the family, the burden it placed on their resources. And the mother, oftentimes when she came to the office, she was tired, She looked exhausted. She lost her job. The young lady could not go to school as she would have liked to, and the financial resources of the family was depleted. And so this really goes to show that chronic disease really has that effect on patients and their caregivers. But apart from that, understanding that chronic disease is chronic and therefore will be with them for the rest of their lives. So all coping skills will be tested to their maximum, And so this is the case that brings that point out. I want to share a second case with you, a 48-year-old female teacher with an elevated body mass index and known hypertensive who came to the clinic because she was uncontrolled with respect to her blood pressure. But in the course of the consultation, she said to me, "Doctor, my husband is diabetic, he has erectile dysfunction, he's very sick at home." Now, this guy was not a member of the clinic. He was outside of that clinic, and usually the patient has to be referred to our clinic. So in that moment, she was able to share information. Her blood pressure was under control at the time. And additionally, she also mentioned that her mom, who is also hypertensive, was home and had a stroke recently. So she was taking care of her mom. She was hypertensive, uncontrolled, and she had a sick husband who was also somebody she had to care for. And so in the consultation, I could see she was visibly overwhelmed. So she was uncontrolled with her blood pressure. She needed to reduce her BMI. She was, and so we needed to start treatment. Treatment was started according to the guidelines, and the blood pressure eventually became controlled. Now, in this situation, in this patient here, what are the factors leading to mental health challenges? Her coping skills were depleted. Caring for herself, husband, and mom certainly was a significant challenge to this patient. She was the healthiest of the trio, and she had her own issues. She was depressed. She was sexually dissatisfied, and she mentioned that in the consultation. And her secular responsibilities as a teacher was not just as a support to her family, but now she had to become the main breadwinner in the family. So what did we do? We called the husband, called the wife, and we started to talk to the family. So in the case discussion, we spoke about adherence to counseling, drug adherence, we counseled with her and the husband. We assured them that their best interest is being looked at, encourage them to join support groups. The patient was asked to bring her husband eventually. The need for a referral was waived, and what I said to her is bring him the very next day. So she brought him in the very next day. He was seen urgently, and so he was assessed, and we referred him to the social worker for consultation. So in this case here, we see a husband and a wife. The wife and the husband were working together. He became sick. She became the main breadwinner. The mother, her mother, who was his mother-in-law, was also hypertensive, and she developed a stroke. So she was someone being cared for because she was bedbound. And the husband then became someone who was ill as well. So she had to take care of the husband, take care of herself, and take care of her mom. So as you can imagine, this is a woman who is tired, she's sexually dissatisfied, financially depleted, coping skills at rock bottom. So she was very much at a point where she was at her wit's end and intervention was needed. Thankfully, we were able to control her blood pressure, get her husband into the clinic, start talking with the family, and beginning to chart a course toward improvement in the family's well-being. So my third case is that of the husband of this lady, who is a diabetic man, came to me looking very ill, significant weight loss, was weak with elevated blood sugars, and he was sick for a while at home. And the wife at this time in the consultation had expressed her observation that they were not having sexual relations because he had erectile dysfunction due to his elevated blood pressures, and so the marriage was was dealing with some issues, as you want to say. So he was a type 2 diabetic with obvious weight loss, weak and wasted, uncontrolled. Treatment was started with the insulin that the hospital provided. That did not control the blood pressure. So I did reached out to the Diabetic Association, and they have long-acting insulin. He went there. It's very expensive, by the way, and so he didn't have to pay for it because of the institution that I sent him to, and therefore that financial burden was removed from the family. So his blood sugar is eventually controlled, and so the initial assessment of where he was mentally, he was depressed, he was ashamed because of the sexual dysfunction that he had, he was frustrated, and so this was a man who was dealing with a whole lot because of his chronic disease. Also, so in dealing with this patient, it was important that I listened to the patient to hear what was being said by the husband, hear what was being said by the wife, okay, relax the rules, which usually requires a referral, so that the husband can come into our care without the paperwork, but just to be seen in a very expeditious way. His medical treatment was optimized and referrals, appropriate referrals were done. And so the patient was reassured throughout the entire process that we are taking care of your needs in this moment. His wife, I say kudos to the wife, she was bold enough and felt comfortable enough to share the issue that they were having. And so spousal support was there from our side to him, and I guess would have been reciprocated as well, because when they come to the clinic, there seems to be a harmonious situation with husband and wife now, that their chronic diseases were being managed and that their mental health was being catered for through the support systems that we have in place. And of course, we refer them to the social worker for counseling. The fourth case is one of a 28-year-old nursing student who had no known past medical history. This is a young lady who turned up to the ER with speech impairment. She had 2 pregnancies in the past, uncomplicated, and was previously very active. When she, but in the past, she did have some depression, suicidal ideations, and when seen, she had slurred speech, inability to pronounce words, mild right-sided facial paresis, memory loss. And when we did our evaluation, she had an MCA territory cerebrovascular accident or a stroke. And this is a huge blood vessel that was obstructed. So she had a number of areas downstream in her brain that would have been affected. Keep in mind that this is a nursing student, a young mother who is in a career path. And so we put her on appropriate treatment, aspirin, statins, and we referred her to speech therapy. So she showed steady improvement in her speech, and there was no movement deficits of any significance, and so we were happy about that. So what factors led to mental health challenges here with this young lady? So she now has an inability to complete her nursing training due to memory loss. She now has dysgraphia, where she cannot write. So for exam purposes, she cannot write well, remembering certain words. So it impaired her writing ability due to impairment of fine motor skills, and it is actually classified as a learning disability. She was depressed. She has expressed suicidal ideation, but never attempted. Now she has to contemplate career change and so on. She started to increase her alcohol use, marijuana use, and so what we did, we sent her to a social worker. She had to go for counseling. We optimized her medications. She was better in terms of her general wellness. We referred her to the neurology department, and I bought her a blood pressure apparatus. I gifted her a blood pressure apparatus to make sure that we knew what her blood pressure was, and I referred her to speech therapy. So this young lady was one where this is a young mother nursing student who was now having a stroke, and it obviously changed everything in her life, challenged her coping skills, and now was pushing her to the brink of suicide. One second. Guys, are you hearing me? Hello?
Yes.
Yes, so this young lady was now challenged as a young nursing professional who was going to launch off in her career and had all the expectations of moving on as a nurse, but then up comes a huge stroke that did not create much motor deficit, but certainly challenges now her ability to demonstrate her academic abilities, to be able to write exams, to be able to speak to patients, forgetting words, having to pause for long periods to try to remember words. And that is a classic challenge we see with MCA territory stroke. So we're counseling with this young lady. We know that she had suicidal ideations. Once let me correct something I said earlier, where she never attempted, she did disclose that there was rat poison, insecticide, rodenticide in the home, and that she was contemplating, and she actually verbalized that she was going to take it, and her mom removed it. So we see a young woman here who was really struggling, and thankfully we were able to get her into some counseling. Her medications are now optimized. We have other services on board giving her support, and she now has her own blood pressure machine that she can check her blood pressure on a daily basis, and she is receiving speech therapy. She speaks much better now. My final case is one in which a young nurse working at the Norton Hospital. Are you hearing me?
Yes.
Great. So this nurse was sent to us with his X-ray. Now, this is not his X-ray, but it's just to create a visual in your mind what we're talking about. And so this young man he experienced some back pains, and he went to his primary physician, and the physician did an X-ray and saw a mass, or what looked like a mass, on the X-ray, and sent him for consultation. So this 33-year-old male nurse was referred to us, and investigations began to discover what this incidental right lung lesion might be. The patient was experiencing some mid-upper back pains and got his X-ray done. But noteworthy is the fact that this young gentleman had a recent history of tuberculosis infection for which he was treated, and that treatment is a protracted treatment for 8 months to a year. And he went through that treatment. He was also involved in a motor vehicle accident, and in that motor vehicle accident, he had a femoral fracture, and so he had surgical intervention. He had to undergo the usual rehabilitation. He walked with a cane for a while, and then eventually he was able to ambulate without assistance and without a need for his cane. Now, during the consultation, this young man was sobbing uncontrollably. He was shaking violently and really unable to control his emotions. And I mean, if you're able to be in that situation, the energy and the emotions in that situation is so raw that you really have to compose your own self as the person offering care to these patients. So he had his past history of TB, he had the fracture, underwent rehabilitation, and when I examined him, he was physically unremarkable. He was sent for CT scan, and thankfully he did not have he had a benign lesion, which was just scarring from the previous TB infection. Factors leading to mental health challenges for this patient was the fear of the unknown. This young man has had a history of numerous health challenges, and he did have a family member who had a cancer. And so his concern with a lesion on the lung is that this is gonna kill me. And so to look at a grown man cry and sob and snot, I mean, I had to really compose myself, because here it is that all of his emotional capacity to control and to remain composed was gone. And so thankfully he had a benign lesion there. Fear of the unknown was the driving force behind that mental health situation. Intervention, he was sent for a social work consult on the very day. CT scan was organized in an expeditious manner, and he was reassured. One second, guys. Yes, and so he was reassured that his diagnosis is benign. There was no worry for him to nothing to worry about, and so one second, please. Yes, and so we were able to help this young man, and in the end, he came back to the consultation in smiles, and we were really happy to work with him. And so this brings to the end the cases that I wanted to discuss with you. Now, one of the things that I usually would want to say in conclusion, one of the things I want to say to my colleagues who see patients across disciplines, whether it be as a physician or you're a psychiatrist or psychologist, you know, there are some basic things we want to do for our patients. We want to educate the patient about disease progression, the management and prognosis. Oftentimes when patients do not know what is coming next, those patients tend to be very uncertain of the future, and fear becomes much more precipitant in that situation. We want to empower them, cause them to understand that they have what it takes to fight the condition, and encourage lifestyle changes, encourage medication adherence for those patients where it's appropriate, and make the appropriate referrals in an expeditious manner, encourage family and group support. And so it's important that we do these things to help our patients. This brings me to the end of my presentation, but I'm open to questions and discussions around any of the cases that we just looked at, and to talk about those mental health challenges and remedies that we can put in place.
Thank you very much, Dr. Anderson. Let's see if you have a question online, if you could please put it in the chat, and I'll start with questions from the audience.
Oh, the person said, we cannot hear him, the transmission is broken. That was a comment. Let me see.
Sorry, I'm getting an echo. Are there any questions for Dr. Anderson? Let's see, I have one, Dr. Anderson. So in your first case of the 14-year-old, the mother lost her job and was just thinking of the Family Leave Act that we have in the US, and was just wondering if there's if there is a family leave type act in Guyana, or if there's any talk of one in the works.
Family leave?
Family Leave Act. So to let families, you know, could keep their job while they're taking care of a family member, and get some money, you know, so they're able to keep their job, when also support their family when they're having illness. Hi, Dr. Anderson.
Hi.
Great.
Yes.
Do you want me to repeat the question?
No, I heard the question.
Sure.
I must apologize. I'm taking this this call from the airport, so the internet was a bit sketchy a few moments ago. So in Guyana, within my consultations with legislators, with senior health officials, and other stakeholders, I have never come across the discussion even of a Family Leave Act, not in Guyana.
Well, thank you, and hopefully policy can come down the line and have some support for family members needing to I'm sorry. No, I'm unmuted. Okay, that's okay. So again, hopefully something will come down the line at policy so people can keep their jobs when they're caring for family members. That's it is such a important outcome that you pointed out in that case. And
yes,
another thought around that case was the idea that it looked like that the 14-year-old had social work counseling, but it almost seemed like the mother might need it as well. Are there cases where you've seen, in that case, were there support services offered to the mother?
So yes, the mother would accompany the 14-year-old to the counseling sessions, and so there was dual counseling happening. However, I think the financial burden that the situation placed on them, because when for the workup to determine suitability for kidney transplant for the father to the child, they had to find a huge amount of money. There are no support systems that were available. So they had to find that money, the money to take her up to the US, they had to find that money. And remember, they were spending money 2 years prior to diagnosis. So they were really financially depleted. And so this mother was really dealing with more than one issue, as you would imagine.